The implantable hearing aids can be divided according to or based on the coupling techniques into two main categories, the bone conduction implant and the middle ear implant. The bone conduction implant is coupled to the skull bone, while the middle ear implant is coupled to one of the middle ear structures, the ossicles or round or oval wound. The bone conduction implant is further classified into percutaneous and transcutaneous bone conduction implant. Transcutaneous bone conduction implant include passive and active technology, while the middle ear implant is further classified into partially and fully implanted devices. As said by Professor Dr. Medhat, all those devices indicated in the patient with conductive and mixed hearing loss who cannot use the conventional hearing aids for medical reasons like external ear stenosis, malformation, surgical mastoid cavity, and recurrent otitis media. In addition, because the bone conduction implant is coupled to the skull bone, they are indicated in the single-sided deafness, and because the middle ear implant can be coupled directly to the round window, they can be used in the sensory neural hearing loss. Now I will focus briefly in each of those 5 categories. The percutaneous bone conduction implant is coupled to the skull bone directly by a skin-penetrating abutment, and that's why it's called direct drive. And they were the first bone-anchored hearing aid to be introduced in the clinical practice in 1977. Currently, more than 200,000 patients around the world have been treated with percutaneous bone conduction implant. The main advantage of this structure is efficient transmission of sound directly to the inner ear and avoiding the attenuation of the skin and subcutaneous tissue. However, the main disadvantage is that it needs osseointegration of the screw, and any failure of this process can affect the performance of the percutaneous bone conduction implant. This is a recent systematic review of 10 years experience with percutaneous bone conduction implant that was published 2020 and reviewed about 20 studies. They found that the average functional improvement was 33 dB, and all aided speech perception thresholds were significantly below the normal speech level, which is 65 dB SPL. About 98% of the patients reported an improvement in the quality of life. On the other hand, complications associated with percutaneous bone conduction implant varied widely among the reviewed articles, and they ranged from 8 to 95%. Skin-related complications, as said by Professor Dr. Wafa Shehata, were the most common complication type and were experienced by approximately 1 patient out of 7 patients. However, only 0.4% of the patients were reported to have skin reaction that require removal of the abutment. The passive transcutaneous implant is formed of an external speech processor which is coupled to an implanted subcutaneous magnet. So here the skin is intact, and that's why it's called skin drive. The main advantage of the transcutaneous bone conduction implant over the percutaneous one is preserving the skin integrity and avoiding the high rate of complications associated with the percutaneous bone conduction implant. However, the main audiological disadvantage is attenuation of the vibrations that caused by skin impedance of about 10 to 20 dB. The active transcutaneous bone conduction implant is formed of external sound processor that communicates with an implanted actuator over skin by radio frequency transmission. The active transcutaneous bone conduction implant was first implanted in 2011 as a part of the clinical trial, and they approved in European market 2012. It is already implanted in more than 200 centers around the world. They have the advantage over the passive one as they prevent the attenuation of the vibration caused by soft tissue. And this is a systematic review of the active bone conduction processes that was published 2016 and reviewed 17 publications. They found an improvement in the functional gain that ranged from 24 to 53 dB. All aided speech recognition scores improved from less than 25% to a score ranging from 77% to 93%. In comparison to the other bone conduction implant, the active transcutaneous implant can be said that the audiological benefits of the active transcutaneous bone conduction implant is comparable to the percutaneous system with less percentage of complication, and it's more reliable than the transcutaneous system. In the partially implanted middle ear implant, they have external part or external speech processor which attached to an internal part through magnet. The internal part is formed of receiver coil demodulator, which modulates and releases the signal through conductor link to a floating mass transducer. The floating mass transducer is coupled to the ossicles or the round window and transmits vibration to the inner ear. They were implemented for the first time in 1996, and currently the vibrant sound bridge model is the only commercially available middle ear implant. According to the Medell headquarters, more than 10,000 patients are implanted with the vibrant sound bridge. A systematic review of efficacy of the vibrant sound bridge in congenital oral atresia that included 27 studies were published in 2024 showed that the functional gain ranged from 31 to 54 to 55 dB. They also found significant improvement in the speech recognition threshold and speech recognition score. Comparable results were found also in the vibrant sound bridge in the treatment of sensory neural hearing loss. The fully implanted devices were developed in 1999, and since that different technology were implanted in the market. In this category, the microphone, the speech processor, and the transducers are internally implanted, and they were associated with major complications that required surgery, recurrence of the surgery in 50% of the patient. 26 of the major complications are device-related, and the 22 are related to the surgery. Currently, there is no available fully implantable devices in the clinical market, in the clinical practice. Thank you.